conversation about the market rules, which again Sonia so expertly set out in her presentation. We have three individuals who are going to guide us through that conversation. First, Kevin Lucia, who is the research professor and project director at Georgetown University's Health Policy Institute. He's also a member of the District of Columbia Exchange Board. Professor Brad Herring, who's a health economist with the Johns Hopkins Bloomberg School of Public Health. And then finally, John Jacoby, who's a professor of law at Seton Hall School of Law. So sort of same game rule, ground rules, about 5 to 7 minutes, and then we'll open it up for conversation.
Why don't I start? Thank you for the nice introduction, and thanks for inviting us to be here. So I run a project that's funded by the Commonwealth Foundation. Our main goal, and Georgetown University has been doing this for a long time, kind of watching how federal law is implemented at the state level. And so we have funding to really watch exactly what states are doing. We call it state action on the on implementation of the ACA in regards to market reforms inside the exchange, outside the exchange, and then other kind of regulatory changes that a state might be making to implement the ACA, either to undermine the exchange or, to make it better. So I have today I'll talk a little bit, I'll just kind of piggyback off what Sonia was talking about in regards to the implementation of the outside of the exchange rules, well, they actually apply more broadly. And then I'm going to ask my colleague, Sarah Dash, who heads up our exchange component research, just to give a few comments on what she's seeing and the trends that she's seeing at the state level. But on the 2014 market reform, so these broad market reforms, guaranteed issue, adjusted community rating, no pre-ex, just like Sonia said, what surprisingly we found that very, very few states have implemented these at the state level, and although we expect more to kind of move forward in the 2013 legislative session that's going through right now, we're not expecting that many to actually end up moving forward. And so that brings up all sorts of questions about, who has the enforcement authority to monitor and enforce these market reforms. And traditionally that's been with the states, and the feds have been hands off throughout HIPAA implementation. And now we have these really heavy lifts that have to take place, and without, we would argue that without, the legal authority to enforce these market reform, states may not have access to all their tools to enforce, and that is, the tools to write regulatory guidance, to assess, to do market conduct exams, to assess penalties if an issuer isn't doing what they're supposed to do. And so we decided, as part of this project, to reach out to states and ask them just offline, do they feel that they have the authority to do this, even though they don't have the express authority under their state law. And I would say, I don't have the exact number in front of me, but 20 states said, we can point to something that may give us some authority, like their form review authority or their rate review authority, that could kind of get them at least partially the way they are to be able to kind of really monitor and enforce completely. But at some level they were limited in their enforcement authority. And so what we expect to see over the upcoming months is some type of kind of arrangement between the federal government and the states, some type of collaborative enforcement agreements that really will, where the states that don't have the legal authority to enforce will agree to monitor and use their tools to encourage voluntary compliance of these market reforms, and then the feds being there to back them up, and so that'll be something for us to watch going forward. But I'm of the mind that the states are in the best position to monitor and enforce these market reforms. It's their residents. They have had this traditional role of doing this, and I think the sooner we kind of shift the authority back to the feds, back to the states in full capacity, it's probably better in the long term for consumers. And so we're interested in exploring, how consumers fare in states that have full enforcement authority, and how states fare in these states that are in partnership with the feds, where the feds are kind of acting as backup. And then I think that there'll probably be some states that just don't, have to completely turn over their authority to the feds. And in those states where the feds are directly enforcing, and I think Sonia talked about this before, do they really have the capacity to go into a huge state and be available and responsive to consumers in the way that the state regulators can do so? So that's the market reforms, and I just want to let Sarah talk a little bit about her work on exchanges and what she's seeing in her upcoming research.
Thanks, Kevin. Thanks for having us here today. So very briefly, I'll just go into what we're doing on the exchanges. We're doing a similar kind of 50 state plus DC tracking project of where states landed on their exchange decisions in terms of, did they choose a state-based, a partnership, or a federal exchange, and why? And we'll be coming out with a paper on that through the Commonwealth Fund. And I'm going to talk about that a little bit. I think we went into it thinking it'd be a little more clear-cut than it's turned out to be. Really, I think we all know there's this continuum of sort of options within the state-based and then with the partner and the federal. And one of the things we're really trying to figure out now, in particular with these state and federal regulatory issues, is kind of how's that actually going to work, and what's the distinction? I mean, the partnership option was kind of something that came in through regs. It wasn't really contemplated in the initial Affordable Care Act, and we talked to regulators and other officials in 12 states, kind of representing the broad spectrum, and some of the folks who chose partnership option and really fought for it said, well, this is going to let us keep control over our insurance market, and we really want to do this plan management function, but now there are some states that are saying, well, we're going to still do the plan management, but we're not calling ourselves a partnership. So, I think it's going to be interesting to see, and then even within the federally facilitated exchanges, how cooperative our state's going to be with the feds, and how is that whole division of responsibility going to break down? Is I think still an open question. So, I think one of the interesting things that we found is that it wasn't purely a political decision. I mean, certainly politics has played a huge role, and changes in state leadership, as I think we talked about earlier, has caused some states to, do a complete 180 on, their decisions in some cases, and probably, we're going to have to keep watching, because we have 34 governors up for re-election, I believe, in 2014. That's scary. So that being said, though, what we found is that states actually did take steps to really think about what was going to be best for their state. So it wasn't necessarily a knee-jerk, like all the blue states immediately decided to do a state-based and all the red states immediately decided to do a federal exchange. So, and I think one of the really interesting things has been the amount of public outreach and stakeholder input into this process has been pretty amazing to us, and so that's something we're going to kind of write about it and talk about the specific trends in our paper. And then the other piece that we're doing is really just beginning now to take a deep dive into how the state-based exchanges are beginning to operationalize their decisions, or have in many cases. And so later, kind of in the summer, it'll be a broader landscape of where they came down on really critical operational decisions, characterizing not just their governance and operational structure, but how they're handling eligibility and enrollment, risk adverse selection, trying to mitigate against adverse selection, how are they trying to maximize participation in their exchanges, and really just kind of trying to characterize the range of flexibilities that states really do have in setting these things up. So that's our work in a nutshell.
I would just add, as the kind of information comes out of the exchange component of our project, these what we're calling critical decision that states have to make to operationalize their exchange. It's interesting because we've identified like around 200 decisions that states have to make, so it's this really messy landscape. And we take a pretty academic approach to this and have it all written down. You can see it on paper. But I'm also on the board of the DC Exchange, and I'm realizing that it's not 200 questions. It's really like 2,000 questions, and they all come at you at once. And it's been really amazing. Right now, the DC Exchange has over 20 working groups to ask some of these questions to give move forward on some of these policy decisions. Right now, I'm leading a discussion on employee choice in the small group market. And it's really complicated, and all these policy decisions are connected together, and they'll shape, how the exchange operates, how attractive it'll be to individuals and small employers, and ultimately how these decisions will affect premiums. And so, it's been a nice flow from seeing how we look at these as state action on paper to actually in practice. So.
I'll go next. So I want to pick up on what Kevin and Sarah were talking about. I want to talk about enforcement from a different perspective. I come from New Jersey, which is an interesting state in many ways. And I'm experiencing a little exchange envy now, because we were, I spent the last year and a half or so working, drafting briefs and policies and so on to help our state legislature and our state executive figure out how to design an exchange, and then our very decisive and free-speaking governor decided that we weren't going to do an exchange. So all that, I just sort of threw all that stuff away, and that whether it's 200 or 2,000, that the FFEs are going to come in without having anything like that kind of discussion with folks on the ground in New Jersey. So I want to discuss how enforcement in a state that has an FFE might operate, and in particular, I want to use sort of my background. I've worked in and out of government. I worked for the governor's office, but I also worked as an advocate representing individuals. So I want to think about a form of enforcement where you assume that all of these decisions are made perfectly. So if you assume that the structure is great, what problems will still arise, and how will you address that? I was very glad to hear Sonia say that really the key to we thought that the key to that sort of consumer protection was going to be the exchange staff. The exchange staff was ideally situated to address those issues. I want to explain why I think that, and how disappointed I am that New Jersey's not going to have a state exchange, which I thought was going to perform very important functions. So I think of how the ACA's purpose, and I think of the ACA's, from my perspective, one of the ACA's most important purposes was to extend coverage and care to the most vulnerable people in society. The people are always left out every time we talk about reforms. We do reforms here, and then the poor and very vulnerable people are exactly where they were when we started. And so I think that the ACA was crafted to address those people, along with the financing issues for the general people in society. So there are sort of three levels of ways that this protection was going to occur. There's the top level protection, guaranteed issue, guaranteed renewal. Importantly, things like risk adjustment, dealing with issues, cross-border adverse selection issues, cross-border in and out of exchange issues. There's a lot of thought given to that at the top level. Very important. It's important to get people in, important to get people into the system. Then the second level was sort of the implementation. How are essential health benefits going to work? What do we mean by actuarial equivalency? Can you go from number 9 to number 10 and all that stuff that we went through? What are benchmark plans? How will we protect people with substance abuse disorders and behavioral health issues? when the decision on essential health benefits was to say, first, that we're in the mess we're in because individual and small group markets haven't been addressing the real needs of people. Second, let's use as our model for the plans those very individual and small group plans that weren't addressing the problems in the first place, and then we'll patch them up a little bit. Well, there are problems that can arise from that, and we all know that, and we're all thinking about how those problems can be addressed. So at that second level, at the implementation level, there's still this sort of architectonic thinking. How are you going to get the pieces in place? It's at the third level that I'm most concerned, or that I want to talk about here, and that is, even if the architecture is great, even if we think through how all these plans are going to work, there's still, even with great risk adjustment across plans, all the different permutations of risk sharing, there still will be incentives on the part of plans to engage in some forms of stinting, engage in risk selection by design, the kinds of things that insurance companies have historically done that disadvantage the very people that I thought the ACA was, and I still think the ACA was intended to help. For example, Ellen was talking about behavioral health and substance abuse. Even if we get all of the design issues right, incredibly important to get those design issues right, because you can't enforce them if they're not right. But even if you get them right, how will the problems that arise when plans don't follow through on what they're obliged to do come to the surface? In a jurisdiction with habilitative care, and you've got without good enforcement, the guy in the cubicle at the insurance company who doesn't know habilitative care from the man on the moon, he is still operating in a 2009 world until somebody hits him on the head with a hammer and makes him operate in a 2014 world. As Sonia described, I think that the individuals who are structurally best positioned to gather the information about faults in compliance and to integrate those into signals to insurance companies are the people in state-based exchanges, because they're the people who have the capacity and the tools and the interest to gather complaints, to investigate complaints, to jawbone insurance companies, or to use their second-level certification authority to kick insurance companies out, at least to threaten that. FFEs aren't going to do that. They're going to do none of that. They're going to be an open exchange so long as they're federally qualified, so long as they're federally certified. You're it, at least in the early years. The feds have been quite clear in their guidance on FFE structure that don't look to us to do this consumer protection function. We will try to do a good job, and I think that maybe they will. Signing people up, the enrollment and retention issues, hugely important issues, but the issues that I'm talking about, FFEs aren't going to do. They're going to reach out and retain navigators, but for enrollment and for retention, the functions that I'm talking about fall out. What does the guidance say about those functions? We hope to work in partnership with state agencies because state agencies are more familiar with people on the ground. True, but the state agencies are the very state agencies that have never done this work in the past. State departments of insurance, even good state departments of insurance, have the conflict of interest that everybody who talked about state exchanges talked about. That is, they're most concerned about solvency, about the going forward value of insurance companies. Secondarily, they're concerned about consumer protection. There has to be someone who is interested in consumer protection and secondarily concerned about solvency. And so I wish I could say, and here's how we're going to fix it in New Jersey. Here's where we are in New Jersey with this problem. All the people who thought we were working towards a state exchange are now looking at each other saying, well, what are we going to do now? And the answer is that it's going to have to be community groups who are going to be doing this work, and not with funding. The feds aren't going to fund it. The state of New Jersey is not going to fund it. It's going to have to be the community groups working together, patching together the funding that they can in order to gather concerns. So community groups will gather the concerns. I'll work with them. I can publish things to the state. The people in the state government know me, so I can issue white papers or try to put together a jerry-rigged form of consumer protection compliance that I thought was going to come through state exchanges. So I'm sorry I get excited, but I'm very concerned about this, and I would love to hear if other folks have thought about this, what I think of as compliance from the ground up as opposed to compliance from the top down. Both very important. The specific question I have is about compliance from the ground up.
Thanks. So hi, I'm Brad Herring. I'm a health economist here in town in Johns Hopkins University. So I thought what I'd try and do is kind of follow on some of this discussion from Sarah, Kevin, and John, specifically focusing on the risk mitigation strategies with respect to community rating and guaranteed issue. I guess for two primary reasons. One is, as an economist, that's kind of the quantitative research I do. So I'd like to think I know a fair bit about it. But I guess the other reason is I can say a few words about what we're doing here in Maryland to deal with some of these issues, and I can speak to that on two roles I have. One is chair of the board of directors for the state high risk pool, MHIP, the Maryland Health Insurance Plan. I've been doing that for a couple of years, and so I can talk about what we've been talking about in terms of this group of, large group of high-risk people, what's going to happen to them. And so I can share what the latest thinking is on that. And then also, to a lesser extent, maybe talk a little bit about my involvement in one of these advisory committees that reported to the exchange, specifically on the SHOP exchange, because there's a story to tell about how their decision, I think, impacted things. Okay. So I guess the starting point is, unlike some economists, I'll come out and say, I think there's just tons of uncertainty about what's really going to happen with the exchange, right? Especially with respect to community rating and guaranteed issue. On one hand, there's a lot of the sky is falling type discussions, specifically about concerns due to adverse selection. Largely in part because the mandates, the individual mandate penalties start off very, very small in the beginning and kind of grow over time, right? So I think that makes folks a little bit nervous about adverse selection on the one hand, but then on the other hand, the subsidies are arguably, right? So I'll say arguably, pretty generous, right? So that those high subsidies ought to be getting folks, especially the younger, healthier folks, perhaps, hopefully, more likely to join the pool. In economics, one of the things, I'll throw out a little bit of jargon and then you'll all stare at me like, what the hell is he talking about? So one of the things we talk about sometimes are non-unique equilibria, okay? And so what am I talking about? Well, there's a very real possibility that things could either push in one direction and it's kind of a self-fulfilling prophecy and we kind of stay there, or maybe in another direction. And so I think what happens immediately with how the premiums come out from the plans, whether people enroll, is going to have a lot to say about whether you migrate towards a world in which premiums are low and everybody's enrolled and everything's functioning really well and you can kind of stay in that stable equilibrium, or things don't get off the ground that well up front, enrollment is low, plans are nervous that the people who are actually enrolling are pretty sick, and the premiums come in high, and then you're stuck in that local equilibrium, right? And so I think this notion about on one hand we've got a lot of time to try and fix these things, as Josh said earlier. I mean, I definitely agree with that. But on the other hand, right, what happens up front and which way you tip can kind of wind up being pretty important. Okay, so one of the things I think people are especially concerned about is that the individual exchange like winds up being kind of like a de facto high risk pool, right? Because there's community rating and guaranteed issue, and maybe people aren't responsive enough to the subsidies, except the high risk people, and the mandate penalties aren't too large, and so one of the things. I hate to be one of those guys that kind of say, "Oh, I told you so," but if I'm thinking back to some of the discussions that folks had here in the state, like 2 years ago or so, after the ACA passed, but they're starting to do the planning. There's the groups that come together, the advisory committees. One of the decisions that the exchange was looking for guidance from stakeholders was whether to keep the individual and small group markets separate, or put them together in a pool. Okay, and so here in Maryland. That decision on what recommendation from the stakeholders came from the SHOP subcommittee, right? SHOP, the Small Business Health Insurance Options Committee, who advocated pretty strongly that keep them separate, right? Well, keep them separate because they're concerned about their pool not being contaminated by all the the uninsurables that will be coming in. From the high risk pool, so I think there was that element. I think there was also, I was kind of advocating almost alone. There's a couple of us trying to think about merging them together. I was also kind of advocating for this notion of like, well, if you think people have preferences for different types of plans, one concern about the SHOP is that there's just going to be maybe 1 or 2 plans available to people, right? And so another nice thing about perhaps merging the individual and small group markets together would be that you could kind of have a model in which small business employees would be able to choose among like multiple plans, right? Well, so it was 0 for 2 on that one, because in large part, the broker community doesn't really like that model, right? They're kind of happy with the model they have right now, which is helping small businesses choose those 1 or 2 plans. So if I fast forward in this story and talk a little bit about what the state kind of has in mind for the high risk pool, the population, right? So the starting point was like, gosh, okay, ACA kicks in 2014, the exchanges are online. Like everybody's mindset was like MHIP, our high risk pool, is just gonna sunset, right? They're all gonna move in to the exchange, and that was our mindset for a while, and it's now not so much longer like what we're thinking of doing. We're actually considering having the high risk pool stay open for a number of reasons, which I'll talk about a little bit briefly. Some of them are frankly maybe decent policy, but some of them are also purely political. From the policy perspective, well, if you look back to the experience with introducing the Part D prescription drug benefit, there was just mass confusion. What would that have been, like October, November 2005, right? And the people who were really most hurt by that were the folks transitioning from Medicaid drug plans or drug coverage into the Part D prescription drug benefit. So one thought we certainly had was well, look, if they're high-risk pool enrollees who are relatively satisfied with their high-risk pool coverage that they've got right now, and they want to stay, well, let's perhaps maybe allow them to stay, at least for a little while, so they don't get caught up in all the confusion and disruption that we hope doesn't happen, but it's probably inevitably going to happen, right? So if that's maybe one reason why it might be good policy, as far as the politics go, well, if you're really so concerned, and I know the Exchange Board is really concerned about getting off on this good fit, and thinking about the story I told earlier about, well, on one hand you could kind of get in this rut of small enrollment, high premiums, or in this other direction of low premiums, good enrollment. A key consideration here is well, there's 20,000 MHIP enrollees who are pretty expensive, and if there's something you can do to keep them out of the exchange and prevent those premiums from skyrocketing, maybe that's not a bad idea. And so what we've essentially set ourselves on a path for doing is using the state funding, and it comes from the hospital assessment here, from the hospital rate setting system, to essentially allow the high-risk pool to continue. But it's more complicated than that, because the high-risk pool can only really continue for the state high-risk pool folks and not the new PSIP enrollees, because the PSIP has to come to a close, the federal high-risk pool. So those federal high-risk pool people definitely going into the exchange. And then the tricky thing that is going to take a lot of outreach from MHIP staff is that, look, for some people, it's going to probably benefit them to maybe want to stay in MHIP, the high-risk pool, because they don't want to get caught up in all the transition. But then there's a lot of people who could really benefit greatly from the low-income tax credit subsidies. And so we're kind of gearing up for a big outreach to try and help MHIP enrollees decide whether they're going to be better off to stay in MHIP or whether they're going to be better off getting subsidized coverage in the exchange, which I mean, it's difficult because we don't know what the premiums are going to be in the exchange. And then the key consideration here for thinking about wanting the exchange premiums to be low, it's in large part like, well, what do the insurers what do they expect going to happen, right? And so in order for those exchange premiums to be low because they expect MHIP to continue, there's got to be like a pretty strong signal that that's going to happen. So with that, thank you again for inviting me. It's been really neat listening to everybody's perspective, especially as an outsider, as an economist. But you've been very welcoming, so I appreciate that. So I guess, yeah. So
Let's open it
to
up for
questions.
conversation, yes.
This is just Cheryl. I just wanted to ask you a question about, two questions actually. One is, are MHIP premiums still above standard rates? And also, did Maryland think about paying sort of a reinsurance fee for those people in the regular exchange?
Yeah. Oh, actually, yeah. So I'm looking at my notes and I'm like, shoot, I meant to talk about reinsurance. I got too caught up on the thing, because that's actually perhaps like a long-term strategy. So the short answer about what the high-risk pool rates are, the state specifies that we've got to be in between 110% and 150% of the market average rate, right? Well, like right now, the market average rate is a heavily underwritten individual market that reflects healthy people, right? Mm-hmm. So if we're setting, and we did this last month in our board meeting, we set rates for the upcoming year based on how rates are now, right? So it's going to be kind of a moving target, but in some sense, we're kind of ahead of the curve in terms of being able to keep rates low. Yeah. So actually, like the broader perspective. I meant to talk about this. I mean, so reinsurance, right? So if you think about the 3 R's in healthcare reform, the risk adjustment, the risk corridors, and reinsurance, risk adjustment works good if you're considering adverse selection between Plan A and Plan B and making sure that they're on a level playing field. But risk adjustment doesn't work if you're considering Plan A, Plan B, and all those folks who didn't enter into the pool, right? You're just kind of equalizing among like the pool, and if that pool is relatively expensive, risk adjustment doesn't work that way to offer those subsidies, but reinsurance does. The catch, though, is I guess like a lot of the things in the ACA, it's short-term and temporary, right? So the federal reinsurance program is just 3 years, and it kind of starts off relatively large and phases out. Well, it's a subsidy, so what that means is if nothing comes in to backstop it, premiums are going to have to elevate as the subsidy moves out, and so. Josh Hartstein talked about, you know, the legislation that's kind of in the mix right now in the state legislature. A small piece of that is actually allowing for the option, right? So not saying this is what we're going to do, but allowing for the option of that hospital, so lots of moving parts, that hospital assessment that's currently funding the state high-risk pool, to perhaps allow that to be used for a state reinsurance policy that comes in to kind of like backfill arguably a good idea, once the federal reinsurance dollars go away.
Elizabeth Weeks Leonard, I'm at the University of Georgia Law School, and I have, I think, 3 questions or thoughts. And the first one goes to some of the points that Kevin was making at the beginning about states lacking the legal infrastructure to regulate or to enforce the new market reforms. And one of my thoughts in reading coverage about that was, news coverage about that is whether that's actually a beneficial dynamic in states where there may be an insurance commissioner who's willing to implement, but a governor or legislature who's not, whether working with existing laws is actually a good thing. I don't know if that's a dynamic that you're seeing. My second question goes to the point that Sonia made earlier about it's not just a matter of how many people we get into the exchanges, but who's in. And one of the issues there is particularly how do we get younger people in and whether they're going to be priced out because of the 3-to-1 rating band. And whether there is, I know, again, from Georgia, there's a proposal in Congress to expand the band to 5-to-1, or at least to allow a phase-in. And I wondered if you could talk a little bit more about that. And then my last question is just a clarification. Again, there is this, or at least there was this question raised by Cato and some other groups about whether subsidies would be available in FFE states. And I know that we all know that that's wrong, but I don't know if that issue is still live. Those were my questions.
I can take the first question you had was in regards to states that politically it's not moving in the direction of
Right.
ACA implementation, and is it better for the legislature not to weigh in on the enforcement piece? And I think
Or at least if it's not going to go anywhere for
right.
the insurance commissioner to
Right.
move forward anyway.
Sure, and if the legislature speaks on this and says, well, something's proposed and they actually reject it, does that limit the commissioner from doing, actually moving forward? And I think it's a, certainly a good question. I would say though, in a state that politically it's not, moving, and the governor's not interested in moving ahead with ACA implementation, typically, unless the commissioner is elected, the commissioner really looks towards the governor for the cues on what they can do. There's certainly some states where the commissioner can evaluate their own law and move ahead and direct their staff to do that. But I came back from a large southern state where the governor is not interested in implementing. And I would say that Department of Insurance really is looking, and that commissioner is looking towards, the governor before they encourage the staff to do so. Brian, you might have some comments here on this.
Yeah, I'm Brian Webb with the NAIC, works with the insurance commissioners, and they're gonna do their job, which is the rates and forms to the extent it allows them to law, but there is a question if the legislature's completely against it or the governor's against it, how much do you want to put the governor in that kind of position of being seen as supporting because they implementing? So they are trying to figure out kind of where they stand. They're having that conversation with the federal government, with SOCIO, which assumes, SOCIO, by the way, just assumes states have the authority, enforcement authority, unless told otherwise. So we're trying to feel each other out as to whether the state actually say it, not say it, who's going to do what. But at the end of the day, the federal government, of course, does have the authority to do fines. And the Department of Insurance has the ability to do rate and form file review and market conduct review and the rest under their general authority. But it is going to be very tricky for the first about 2 years, frankly. Just a kind of a little dance as to who does what and hoping the plans just do the right thing for a while.
I mean, I would say we've heard from states where we, politically, it doesn't look like it's happening, at least the political debate.
Mm-hmm.
But when you talk to the state regulator, they're doing exactly what Brian said. They're gonna do their job and do plan management. They're gonna review forms. They're gonna review rates. They're probably gonna be highly collaborative with the feds. But that's some of them. The other ones, I don't know if that's true. And I think those are the ones that we need to be concerned about. And I think that, and it goes back to my last, my statement before. If you're in a state where the feds are enforcing, We have to remember the federal government has not done this on the private side, except for a minimal amount during HIPAA implementation, and that is not the same game we're in today. And so I think that folks that are interested in consumers and consumers getting these protections in place and really feeling these protections in 2014, even in FFE states where the feds are directly enforcing, I think it's important to continue to watch the experience of consumers. And I'll tell you, consumers are not going to be calling the feds. They're going to be calling the state regulators because that's what they've been trained to do. And on top of that, consumers, they often don't find even the state regulators, but when complaints do come in, I think they find their way to the states. So even in the FFA states, I think we're going to need to be highly collaborative with the state regulators to find out what they're hearing from their residents about their protections, even if they're not directly enforcing them.
And just on that, if I may, a lot of the states are trying to leverage the NAIC, because we have a lot of systems, for rate and form filing systems, for complaint receipt systems that most of the states use. So we're trying to the extent, so if a state like Missouri can't really do anything, I know there are a couple people from Missouri, I know, but they're really underlocking and do a whole lot. They're at least saying, well, if you can collect it through the NAIC and get it through that way, we can then get it to the feds that way. And we're trying to make sure that the feds and us are using the same systems, using the same terminology and things, so we can get things done as quickly as possible. So.
Yeah, I think even in states that the feds are directly enforcing, they're going to be relying on the state regulators in a heavy way. I don't know. I can't see a path to doing it otherwise.
To your other question,
Yeah.
you're saying, and maybe Sonia, you talked to a lot of states too, so I don't think any of them are thinking about it. I mean, none of the states we talked to, as far as like, why did you decide one thing or another?
Right.
I know one. Are you talking about the Cato thing?
The
Yeah.
Cato, like the,
Subsidies aren't
the
available in
subsidies aren't
FFEs,
available.
right.
I mean, it was more.
I think it's still politics. I mean, I think
yeah,
it's
it's
like
like
conservative.
Oklahoma has a lawsuit that is
Yeah.
live right
And,
now.
It's
and
still
Arkansas is having Senate ledge hearings and Michael Cannon's on their testifier list.
Right. Yeah. It's interesting.
Mary Jo, you had a
Yeah,
question?
and I wanted to respond to, John Jacoby's, consumer paradigm, consumer protection in 3 levels, and maybe relieve you a little bit of your exchange envy. And I thought you pointed out the conflict of interest in the MIA, or the insurance administrations, in their first view with solvency, but I think to look at the exchange staff as the Consumer Protection Bureau is maybe not recognizing that they have some conflicts of interest too, and getting to Brad's point about the desperately wanting not to have the small number of high-risk people starting off your year, right? And so, I kind of see the staff being very concerned about getting the carriers in and maybe, not making rules onerous, not being overly, extra stuff, we're not gonna do too much on network adequacy, we're not gonna do, because we want you to play, and already in our state, we don't have a very competitive market. We don't have that many carriers. But the good spot that I see in Maryland is we have an amazing consumer advocate in our AG's office, who is on top of this stuff, is always being the voice for it, sees things I don't see. Looking through the law and saying, we really need to add this to the legislation, or and advocating for consumers there. And she's very independent. She's focused on consumers, and they are the office where phone calls go to answer consumer problems. And so, someone truly independent, that is their first job is consumers, I think, is a real benefit, and we have that in this state.
Yeah,
The lack is that she doesn't have a lot of leverage over the exchange staff, but. That's.
But she has a bully pulpit, and I think
She
that's an important thing. And it's I overstated it because now that I don't have it anymore, I have forgotten all the problems that I
Not
saw.
like relieve you of your exchange envy.
One other thing about that unit in the AG's office, they collect data with their consumer complaints, and they, in old days at least, put out reports, to say, utilization management is an issue. pre-auth is an issue with these drugs, like, they would know where the hotspots were and they could solve things at a policy level because of it. And so, I don't know that insurance commissioner's office are gonna be in a position to kind of collect consumer complaint data and organize
Well,
it.
that's what we do through our
Yeah.
NAIC systems, and
Yeah.
so 3/4 of the states use it, and more will probably come online, and be using the same terminology and everything for a change, so we should get a bit more data, yeah.
Well, and also, I mean, we have to remember that the ACA in 2715A really gives the secretary and also states huge power to collect a phenomenal amount, basically an open check, really, to collect whatever they want. That provision has not been implemented so far, and I think that's unfortunate for people who are interested in collecting the right data to understand consumer experience and issuer behavior after 2014. And I actually was in Society for a year, and I kind of thought that what we were going to do in 2715 was really use that to figure out those data points to understand, as I was saying, consumer experience and issuer behavior. And we're not going to have that. I would say, the exchanges at the state level have a unique opportunity to collect this data, and for qualified health plans. And I hope that DC goes down that road and does kind of use that opportunity to figure out what to collect and when.
So, hold on a second. We have just a few more minutes for this, but I know Jennifer had a comment, and Roger, you had a comment.
A question or comment or both. And that is, on the Medicaid side, when these issues would come up, you sort of had this time-honored tradition of going to court. Legal service lawyers or whatever, on behalf of their recipients, or for services, whatever, could go into federal court, state court, less and less so, but it's there. I'm just wondering if there are going to be many legal handles on the exchange side, since the law is so much all over the place, since the standing issues, it seems to me, would be problematic, whether you go into federal court, state court. I'm wondering how much, and this is probably not the place to start such a long conversation, but how much of whether litigation will be, whether the judiciary will be playing much role in enforcement.
And we may get into that just a little bit with Peter as well. Jennifer, do you want to?
Yeah, I'm Jennifer Goldberg. I am with Maryland Legal Aid, talking about legal services lawyers, and I serve on Maryland's Health Benefit Exchange Board. One of the folks who've helped put together these advisory committees that I think have been really essential. I think we can't forget the importance of community-based organizations for gathering information of what's happening with consumers and making sure that those community-based organizations know how to get that information, because, as a legal aid lawyer, let me tell you, come into our waiting room and we can hear all about the problems. But then how do we funnel that to the right place? And hopefully we know about, here in Maryland, our AG's office, Health Education and Advocacy Unit. We know about what's at the Insurance Commissioner's office, but making sure that that's true in the FFE states, making sure that's true all over, and that community-based organizations know that, and also connecting this up with the navigator and in-person assisters and making sure that they know how that fits together. We've been spending a lot of time in Maryland thinking about navigators and all forms of consumers, in-person assisters and certified application counselors and anything else that comes out in the next reg that tells us there's something new. But I think we need to get everybody looped in.
Cheryl, did you have one more? And Sydney, I'm sorry, you're fine. Cheryl, last
Well,
question.
I wanted to mention the Maryland Attorney General's office is funded in part by these consumer assistance program grants that are federal. And a number of states established, Maryland already had a program that they supplemented with this funds. A number of states established new programs or significantly increased the insurance department's consumer assistance staff with the federal funding. Whether that federal funding, whether there's another round of grants this year is very much up in the air, so that's another issue to think about.
And so there isn't a better segue to talk about, the next panel, which relates to, obviously, consumer participation and access to care than we've begun to talk about. So three folks who are going to lead off that conversation are Professor Bree Clark, who's with Loyola Law School, Dr. Peter Bielenson, who is the Chief Executive Officer of the Evergreen Health Cooperative, which is the co-op plan in Maryland, and then Cheryl Fish-Parsham, who is the Deputy Director for Health Policy with Families USA. Cheryl, were you going to lead off this conversation, or Bree? I think you were going to go first. I think you're going first. Thanks, Bree.
So, thanks for having me. I'm learning a tremendous amount being here, and I feel like everybody's been talking calculus, and I'm going to come in with pre-algebra, because, the focus has been on really complicated and detailed technical decisions that have to be made to make all of this work and happen, from the exchanges to plan design, actuarial, kind of concerns about pooling risk. And all of this, though, as was said at the very beginning, is premised and depends on people wanting to actually be a part of it and enrolling. And at the most basic level, that means that we have to be able to communicate with people to get them to understand it's here, what it is, how to use it. And so I'm going to talk at the most basic level, and I think my the other discussion leaders are going to get more detailed and sophisticated about it, but especially what they're doing. But just a couple of things. So our focus is on access at this implementation stage. So we're talking about from the very beginning of screening and eligibility, which is a critical part, figuring out who can get what, then getting people enrolled, which involves, of course, choosing a plan, and then retention, I want to mention as well, keeping people involved, especially as there may be a change in circumstances or eligibility. On the screening and eligibility side, we've already seen that there may be some challenges just based on the different kinds of programs, documents required, eligibility requirements, and what's needed. We know already that people dread looking for insurance. Dread it. It's just one of the most challenging things for people when they even get to do it or have the experience to do it. But even where you don't have choice, where you're talking about a public program where it's just a matter of going to try to become eligible and get signed up for this program that will be free, we know that there are lots of people who are not signed up for things that they're eligible for. Why? Because it is challenging, or they perceive it as challenging. Because of the number of documents that are required, or oftentimes even because of the experience in just trying to get that information to somebody and learning what they're eligible for. So a huge part of this being successful is the mechanism through which consumers will be kind of interacting with consumers, either the states or the federal exchange, and giving them information, helping them find out about their eligibility and enroll in a way that's easy and friendly. And so a couple of things to highlight about that, and some things mentioned earlier. Enrollment. So one of the most challenging things here is going to be managing the choices that people are going to have. One of the kind of big selling points of the Affordable Care Act was choice. You'll have choice. It's a great thing. Intuitively, we know it's a great thing. But actually, even intuitively, most consumers don't want too many choices. They'll tell you that. They know that. And we actually have studies and kind of sophisticated people who've looked at this in the consumer marketing area, and they see that, in fact, too many choices creates cognitive overload and makes it really difficult for people to make choices. Now, that doesn't mean they won't choose anything. We know that people often will just go to a default plan where there's somebody helping them. So we know, for example, from SHOP plan, kind of prior attempts or kind of ongoing exchanges for small employers in certain states, that in many cases people don't understand what their choices are. So if there's an agent or a broker, they just do whatever the agent or broker says, which means we're putting a lot of power in the hands of the people who are going to be helping consumers. And it also affects the possibility of concerns about retention. Because if the consumer doesn't feel vested in the choice in the first place and then doesn't have a good experience, to the extent you had that customer, now you're going to lose that customer pretty easily. So in terms of choosing plans, so there are a couple of challenges for consumers in choosing plans. So one I already said is possibly too many choices, which some exchanges are constraining by being active purchasers. So that's actually helpful for consumers. The other thing is, how do you even know how to compare value and benefit and what that means? So we already kind of talked about the example of cost and kind of thinking about the cost of a plan. Is the cost of a plan the premium you have to pay every month? Is the cost what your out-of-pocket cost will be? How do you figure that out if you don't know what the deductible will be, what what your co-insurance will be, what kind of disease you will get to even have a sense of what those numbers will look like? Many people who are uninsured actually haven't had experiences with the medical system. They have no idea how to estimate medical costs. They're the healthy, right? They're the ones we really, really need the people who have absolutely no idea unless they happen to work in a hospital billing department, because even oftentimes healthcare providers, many of them don't know what things cost, right? The healthiest people who have no experience with this, they have to somehow be able to understand what their possible exposure would be because of what medical costs might be for them. And they have to feel like there's a realistic chance they'll need that, despite the fact that they've been really healthy and fine so far. Riding their motorcycle with no problem, right? Or, kind of going hiking, going surfing, doing whatever, no problem so far. So there are certain kind of assumptions, right? A background experience that consumers are coming with that we need to actively engage. And so whether it's educating them about certain things in terms of medical costs, but also educating them about statistics for things. So I'll use California as an example. I think California has been pretty good at engaging stakeholders from the very beginning of its exchange to try to figure out what stakeholders want, what would be helpful. And they even use them to try to figure out what plan designs and cost sharing options would be helpful before they standardized. So they brought people in and they educated them about different terms, what copay means, coinsurance, deductible, how to figure these things out. And then they asked them, so would you prefer a plan, for example, that has a bigger deductible, lower copay, or lower deductible, bigger copay, all these things. And consumers answered one way. And they had trouble answering this even with the education about what those terms mean. By the end of the focus group, they still had trouble. They couldn't distinguish those terms. This is with active education. But then the people doing the research did something interesting. They gave them statistics. They asked them, why did you pick this plan? And what came out is a number of people assumed that they would need a certain amount of hospitalization based on their age. And they just assumed that at a certain age, people end up needing a lot more hospitalization. Those bills would be the big ones they'd be worried about, and that's why they chose what they chose. And then the people gave them statistics showing them, actually, this is how many people really need this kind of hospitalization at your age versus other kind of care. Once they got that information, then a good chunk of them, not all, but a good chunk of them changed their preference. This is a really intense process, right? Where we feel like we got better information from the consumers and that they could make better choices. And these are consumers who still didn't completely understand everything they were choosing by the end of the process. And so we have to ask ourselves, how can we, are we going to do this? Are we going to expect the people who are enrolling consumers, the navigators, to be this engaged? Is there something we can do with technology and with the way choices are presented to actually help consumers get some of this on their own? Because it is a lot to expect, probably an individual, to be able to do all this kind of education and help them make these choices. And so we see some things being done already. People have talked about, for example, choice architecture, right? So using the internet, using the design of the information to not only constrain choice, but to give people a certain kind of information to help them make comparisons. So how do you learn about what your out-of-pocket cost might be for something? Well, pick some things that are common. Pregnancy, diabetes, other kinds of prevention if you have kids, like things that people might need, and they can even pick. And then you've got the scenario right there with computations already done. And so in part, it's educating the consumer, not just giving them information, but really educating them about how to even understand the value of that product. Because if you don't do that, if you just give them a bunch of money, a bunch of dollar signs about what they're going to have to spend, and they have no way of valuing it, you're not going to get the people that you need the most in order to make this work. Other thing I just want to highlight has to do with trust. So insurers they have a bad reputation in many places. They just do because of a lot of things going on. Some places worse than others. California, illegal rescissions were a really big deal. Insurers had been raising rates a lot in the individual market, so they've lost a lot of trust there. And so the exchange is a new regulator, but it is the government, right? So to the extent people trust the state government, it's great, and you can build on that trust. But to the extent now you're partnering with people that the consumers don't trust the plans, then you've got to kind of think about how you are marketing yourself to the consumer, what you're guaranteeing for them. The other thing is not everybody trusts their state government. And so one of the examples that came out is a great report by Roundtable put on health literacy, which I'll talk about in just one more second to finish this up. But one of the stories is how a woman who was eligible for Medicaid refused to sign up for Medicaid because how she was treated by the county's Department of Welfare. And this is not unusual. So there may be a lack of trust and problem from other agencies that you have to overcome. So I know this is a lot, right? People are, they're trying to figure out all the details. That's why I said in some ways this is the most basic, but in other ways it's probably one of the most challenging because it's addressing things that many of us take for granted in certain ways and that should feel intuitive and that and may not be. But it also requires some expertise that actually we don't have, even those who think we're great communicators in some respect. I mean, we're talking about psychology and a lot of this, and talk about literacy, all of these things that a lot of people may not have the expertise for. And so that's why I want to kind of finish up my little introduction about the role of health literacy and the importance of this. And as I said, the Institute of Medicine just did a great roundtable with amazing resources about what people are doing. And I recognize a lot of people in here, from Families USA to NAIC to NASB to National Health Lab Program, I know has been part of it, is already doing great stuff in this area. But just kind of very briefly, health literacy kind of traditionally has been defined most narrowly as an individual trait, right? Somebody's capacity to obtain the information that they need in order to make good health decisions. And it's also tended to focus on making the actual health, the medical decisions, medical management. But it is much broader, and kind of with reform, there are new opportunities and challenges in dealing with health literacy. So health literacy is not explicitly mentioned in most places in the reform, at least with respect to the exchange and implementation. It's kind of mentioned in a couple of other places. But in fact, implementation depends critically on people being literate in this way, health literate in their ability to get this kind of information. And this goes to a broader definition of health literacy that at least the federal and many state governments understand, and even plans now, that it's actually an interaction between individual skills and the system demands. So all of the things I just talked about, if seen through a health literacy lens and kind of using health literacy expertise, much of this work has actually already been done. So there are people who are experts in this and who know how to present information in ways that are more readable and that know how to use health literacy interventions in ways that not only facilitate choice but educate consumers in ways that actually improve their health literacy, so they become better consumers going forward and get the experiences you want. And so just a kind of other note to make it even more complicated, what comes through in much health literacy research, as well as kind of anecdotally through experiences that consumers have already had and provided to consumer-based organizations based on other kinds of, dealing with public benefits and other things prior, is that, understanding the information, part of it has to do with the environment in which they're getting the information. So avoiding a shaming kind of environment. So a lot of the terms I already said that we're talking about, people didn't understand after they got a lot of education from an individual. So if you have a navigator who's assuming a certain level of knowledge, that navigator is going to get frustrated with the consumer. The consumer is going to feel it, being either embarrassed or angry, and probably stop. And so, like I said, we're talking about psychology. An important part of this working is the system itself. How is it set up in order to help people navigate it? Language, people who are limited, have limited English proficiency. translation services, interpretation, those are important pieces explicit in ACA. But translation, literal translation, does not work to accomplish what most people need to accomplish. It takes a lot more. You have to have something equivalent knowledge of context and culture. So I can talk more about what people are doing to help this in all these different areas.
Great, thank you. Why don't we go to Cheryl, because that probably is a good segue into.
Sure, I'm going to kind of give a smattering of different issues that I think relate to this topic. I guess first, to build on what Bree was saying, there's navigators are being funded out of exchange fees. In addition, there are in-person assisters that are funded from federal establishment grants. There are hotlines, there are certified application counselors, which may be volunteers, and then there are the consumer assistance programs that we don't know whether they will be refunded or not. So those are sort of the resources that may be there to help people through these decisions. We know that for the federally facilitated exchange navigator, the announcement for first round navigator grants is going out next week. We hope people will apply. But when I saw how many of you were related to law schools in some way, I thought this was my opportunity to make a plea that there are not enough resources, and law schools are definitely going to be needed in all of their capacities to back up these resources. There are going to be a number of difficult decisions that may be beyond the scope of what navigators can do. They involve things like, how should I construct my household for tax purposes? What does this mean for my child custody arrangements? What's best in my interest given this new overlay? What if my employer tries to retaliate against me? How much of my premium credit should I take in advance, given that I might have to pay some of it back if I've not estimated my income correctly? It's now the end of the year. I'm subject to repayment because I didn't estimate my income correctly. What can I do with IRS to do a payment agreement? Am I qualified for a hardship exemption in advance? There are some very sophisticated issues here. There are at least 3 different appeal systems, probably 4 that come into play, depending on which of those issues it is that you have. And there is definitely a need for law schools to do backup assistance on all of these issues. So that's my first issue. The second thing I wanted to talk about is that right now there are others have talked about the really important consumer input and advice in going to state exchanges and the importance of a feedback loop as this moves along. There are also decisions that states are making now about how Medicaid and exchange eligibility will coordinate, and exactly how seamless will it be, and where will those trade-offs be between the Medicaid agency and the exchange entity with applications? What will be the language access capacity at either level? Those are all very important to consumer protection. And then I wanted to kind of hit a few issues about consumer-friendly policies that exchanges and states might or might not be developing right now. And the one that I care most about at the moment is tobacco rating, because final rules just came out about tobacco rating. They allow insurers to charge 1.5 times standard rates to tobacco users, and these are outside of the premium credit. So you might be entitled to pay 2% of your income on insurance due to a premium credit, but on top of that you might be paying $350 more a month if you're a tobacco user for which there's not a premium credit. The final rules also say that a tobacco user is defined as someone who has smoked regularly during the last 6 months, and I'm not sure during exactly how much of the last 6 months, that is not yet clear in the rules. But that means that what happens to someone when they smoke? Does that mean, what happens if they smoke and they enter tobacco cessation services? Does it mean it's a full 6 months before their rate goes down? If you go into a plan and you haven't said that you're a tobacco user, but then suddenly you go to try to take advantage of free cessation services, does the plan go back and say, oh, you didn't tell us you were a tobacco user, now we're going to charge you 1.5% the standard rates, even though cessation services were supposed to be free? I think there are just a lot of problems that we're going to see about tobacco rating. And states right now have an opportunity to do something about it at the state level, because the federal law says that states can do more to restrict tobacco rating. Unfortunately, a lot of state legislative sessions are winding up. It's not a great time to suddenly have this rule and know that this is left to states to do something about. Some states in their exchanges are thinking about banning tobacco rating in the exchange plans. There might be ways to push plans to do something about looking at when people enter cessation services, how they treat them. There might be something to do about how will you treat people who are eligible for cost sharing assistance, where you apply lower rates to them. But it's just an enormous issue that we all need to be paying attention to. There are a few other issues that I just want to mention briefly that state exchanges are taking up. One is cost-sharing structures. Are they standardizing cost-sharing structures to make it easier for consumers? Are they trying to make sure that at least some plans have low deductibles? Another is provider network adequacy. Some states already had laws on the books about like HMOs and having adequate networks. Other states didn't, and so some states are trying to pass rules about that in their exchange plans. Overseeing plan marketing, I think this is a big one. I think we're going to probably see a lot of fraudulent plans pop up, and I know you've said that too. Some states are trying to make sure that there's a logo, a state logo on everything that's legitimate, so that you can identify what's legitimate a little bit better. There are some states trying to provide good information about plan quality. There are some states doing things to assure continuity of care and make sure that as people move from Medicaid plans to exchange plans, they can use some of the same providers. So those are sort of just bulleted list of issues.
Thank you very much. And Peter, would you like to round off the presentation?
So I'm actually the unique person in this group. I had an insurance company, albeit a unique one. I'm the head of the cooperative under Section 1322 of the Affordable Care Act, just to give my bona fides, I guess. I was 20 years as the health commissioner of Baltimore City and in Howard County, Maryland. So I've spent most of my time with vulnerable populations. And the reason that we decided, many of us from the city health department and the county health department, to jump to run the co-op is because we're convinced our mission is to serve basically working families and individuals who are still going to find it unaffordable in many ways, even with the premium subsidies. So our goal is to come in with a product, which I won't go into, some of you know about, that is primary care-based, evidence-based practices, payment reform, and telemedicine, which our actuaries say can save a significant amount of money. But that's why we did this. So I kind of echo both Brianna and Cheryl's comments. Number one, it is vastly too complicated for the average consumer, even for, I would argue, many of us in this room. We're talking about the complexities. I know Brad will jump on me, but this is the single best evidence for why we should have a single payer system. There's no way that the average citizen can go through this without a navigator. We work with our program in Howard County called Healthy Howard that was for the uninsured population, similar socioeconomics as the premium subsidy group. They need a navigator, and it'll be hard to find who the navigators are. There may be 90 different entities in different states that are running navigators. There may be 5, but there probably will not be enough, and it will be difficult to find them. Second, the average consumer has no idea about what's in the Affordable Care Act. We run focus groups to do our research before we do our marketing, which, by the way, the federal money is not allowed to be used for in co-ops. Unlevel playing field, point number 1. I'll get to the other 2 in a second, where I have a plea to some of you. The focus, no one even knows about the individual mandate coming. They do not know. They do not know what's in the Affordable Care Act. We all read the New York Times. The average citizen who is through Maslow's hierarchy of needs, or Maslow's hierarchy of needs, Maslow, is dealing with rent and getting their kids to school and making ends meet, do not know what's in the Affordable Care Act. And as much education as we want to do, there will not be anything near the education that the insurance companies are putting out there. Third, I echo Professor Clark's too many choices. My dad's a retired congressman. My job is to know healthcare policy. When Part D came into being, he was covered already, but we pretended as if he was just a Medicare recipient. He helped to write Medicare law. This is my job, and there were 48 different iterations in Montgomery County, Maryland, where they retired, and we could not figure out ourselves what would be best for him. Fourth, who steers people? I would like to think it's the navigators. We're supposed to have unbiased participation in terms of consumer protection and how people choose their policies. But let me give you 2 examples of what's happening here in Maryland, the bluest state now in the country, more than Massachusetts, I would argue. First of all, captive producers. By the way, for those of you in public health, there's a whole different language. Well, you guys all know this, but for me, it was a whole new producers. What the heck are producers? Well, they're brokers, of course. In the shop exchange that Brad was referring to, brokers were going to be the ones who would take people to market, if you will. In the individual exchange, which is going to be by far the busiest in Maryland, it was supposed to be navigators and an unbiased approach. But captive producers have arisen in recent amendments to our state bill, and they are allowed to do 2 things. Captive producers are those hired to be exclusively brokering on the individual exchange for a insurance company. Let's just use Blue Cross Blue Shield, because they're 70% of the market in Maryland, and clearly have something to do with these issues coming to the front. So captive producers can do 2 things. Number 1, they are allowed to go after people currently enrolled in their programs, pre-exchange, and enroll them. I've had arguments with our exchange director, and healthcare reform director, and Josh, about why they're allowed to do this. I'll even grant the reason I understand the reason. They don't want to have an exchange open and people currently enrolled not enrolled, so you have fewer people enrolled after healthcare exchange. I'll grant them that. But the truly outrageous things is that captive producers are allowed, once they are contacted, once the company is contacted by an uninsured person or someone on another plan, to go after them exclusively. So if I were smart and I were Blue Cross Blue Shield or Kaiser or whoever else in the state, I'd send a postcard with a 1-800 number saying, for the cost of a cup of coffee a day, you can get low-cost health insurance. Call this 1-800 number. And then you're called, and you can send out your captive broker to sign them up. Well, gee whiz, we're 8 months away from actually 214 days away from October 1st, when the exchange opens in Maryland, and that's exactly what they're doing. We have the postcards that people in our office have received. So you have $30 million at Blue Cross. You hire as many captive brokers, i.e. agents for you, to go out and contact personally everybody who's called in or emailed in or whatever, this 1-800 number and URL or website, and you sign them up. A huge competitive disadvantage. Now, I will grant there is consumer protection language in this amendment, which says you have to, as this broker, when you talk to the individual signing up, you have to do an attestation. You have to have them sign an attestation that you have disclosed that you are a blah, 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 that I only work for, and you could potentially have a lower cost on the exchange if you go to the navigator, but here, sign this quickly that I've told you this, and you sign on. We want to have, we would like to prevent this from going through the legislature. We hope those of you in Maryland would help us with that. One further point of just how unlevel the playing field is. On the exchange, with the many, 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 many choices that will be there, there are quality stars given to each company that's offering on the exchange based on pre-existing insurance offerings. Obviously, not what you've been offering on the exchange, because they haven't been offered yet. You can have up to 5 stars. Well, we're new, and we think we're vastly better than the other options, but we're not allowed to, we're either no stars or we can make up our own little language, which will of course be governed by the exchange. We think this is grossly unfair, and we would like to have your help, and Mr. Schwartz, talking about standing. We would like to file an injunction against the exchange from doing so. So anyone who has any good ideas from the 14th Amendment, because as our Supreme Court has decided, corporations are people. But somehow, some way, if anybody can help us come up with a way to file an injunction against this, we think it's grossly unfair that companies who are offering previous things that are giving different quality ratings are offering something new on the exchange that get that quality rating, while we come in being lower cost and vastly better value and having no quality ratings whatsoever.
We suggested Peter throw that question out to this group.
Mr. MD, JD.
So questions and comments, Sarah?
Hi, thanks all for great presentations, and just want to add a little bit and just say that the Senate Commerce Committee held a hearing on the summary of benefits and coverage, which I think you were alluding to, right, the coverage examples on diabetes and maternity care. This past Wednesday, and I won't kind of summarize it all here other than to say, you know, I think the news about it was pretty positive from the standpoint of, you know, for those consumers that it is reaching, they're finding it pretty helpful, although there were kind of mixed views on how to make it better. But I won't kind of go into it because I wrote a little blog about it, and you can read it in 5 minutes and don't have to read the hearing transcript. And it's up on our website. But that's, you know, it's another tool that's out there.
I'm Anne Marie Marsharelli, and I'm from the University of Missouri at Kansas City. I just wanted to add something on to what Cheryl said about tobacco banding. So if you understand tobacco banding from what she said, you also have to understand we have the perfect storm, because what's the other characteristic on which we can ban? Age. So I always tell my students, if you're an old smoker, you're still going to be uninsured or uninsurable, okay? Now, old smokers, those of you who are in public health know, are more heavily addicted, right? Not representative of the addiction intensity across the population. So however you feel about using the exchange to try and implement public health goals, and you can see my skepticism on my face, reintroducing all the things we fought to get out. I think, like, when I think about my best moments about the Affordable Care Act, I think about remembering the forgotten people. Okay, people who age out of employment in the economic downturn. You notice how neutrally I phrase that. Okay, who are waiting for Medicare is what I call them. Okay, who smoke are the forgotten people of this unhappy confluence. And I think we all ought to be thinking really hard about this. And so I just wanted to say a little more. I wanted to say one other thing about what you said, Brietta, about the sort of experience of people resisting Medicaid enrollment because of unhappy experiences with welfare or public assistance. Some people here may not appreciate that welfare and Medicaid enrollment are pushed down to the county level everywhere in California, to the very, very lowest level. And indeed, the stories are legion about how the experience of qualifying for Medicaid is a county by county experience in California. And I mean that in the funniest of ways, okay? That eligibility is determined by your county office and your experience there. So in fact, the legacy of Medicaid as being what in its origins, a piggyback program on public assistance, haunts us still. Right? That we still have not managed to separate it out as an independent health insurance program. We still live with that legacy. I just wanted to say that. Tim.
I just wanted to piggyback on what you were both saying about tobacco, because I was staffing the ACA in the House, and we were losing some of our most progressive Democrats on the issues of tobacco because people just intuit that we should blame the smoker in this. and urge you to be careful about it as you talk to legislators about this. But I would then offer that some of the most compelling advocates against the tobacco ban stuff were the American Lung Association. And if you, because they really are vehemently opposed to smoking, but really want to help with the insurance of these people. So if you actually end up going to your state legislators or to the insurance commissioners or somebody, take the Lung Association with you. They're the only people who convinced some of the wayward members now.
American Cancer too is on this.
And juvenile diabetes, if you're talking about obesity.
What are some other thoughts and questions? Any suggestions for Peter?
I would just echo that, you know, it is a big issue. It's an issue too for the last issue you spoke about, in particular, the quality rating and accreditation for Medicaid managed care plans that I think we have a lot of incentive to bring into the exchanges are confronting the same set of issues. And, you know, the only thing we've been advising and seeing them do is pushing hard on the exchange to say, you know, you have state quality data you collect, thinking in New York specifically, we can use a state-specific quality rating. There's a more level playing field there, but that, you know, we shouldn't have this star rating system out there. We shouldn't be requiring accreditation on day one, because those are barriers to entry, and they're anti-competitive for really good quality plans that we want in our exchanges and we want enrollment.
I have a question. Peter, is your co-op going to also look at other states? Will you be, or just Maryland? What about DC, Virginia?
Well, the fiscal cliff killed off all the rest of the co-ops, so, and none of the surrounding states or DC has one. So if we're successful in Maryland, which is questionable, we'll look to do that, but not for a few years. DC would be first.
It may not be particularly relevant, but just playing off what you guys are saying about Medicaid and stuff, I want to put a consumer front and center, and the poor woman that cleans my house, single mom, disabled kid. She doesn't have insurance. Her kids have qualified for Medicaid on low income. One's disabled. Finally went through the paperwork to get her on SSI. This is Maryland, right? Montgomery County, progressive county. The letter she got going from the Medicaid system to the SSI system was, you no longer qualify for Medicaid, you may not have any of the same doctors in your network, quoted COMAR regulations. Her first language is not English. She speaks pretty well. She's like, was in tears. She's like, why did I do this? Why did I get my child on SSI? Because now I don't have Medicaid. I go, no. You have Medicaid. You're SSI, you get more money, this is a good thing. I couldn't understand the letter. And so this is a woman who, when the exchange comes up, is the person, the parents of these kids who are low income, that's going to either be on Medicaid or in the exchange. And, you know, she, again, just to put a real face on it, she has no idea. Her experience has been horrendous, you know. Even though her kids are on Medicaid and now doctors, she canceled all the doctor's appointments for 2 weeks for this woman because she got this letter and she didn't know what to do with it. The caseworker didn't call her back for 3 weeks in Maryland. And then finally, I sat down and called 36 people to find out what was going on. And finally we got to the right person in the state that could fix her problem. There's some stupid computer glitch in the SSI that makes her 9-year-old disabled daughter automatically head of household that they have to fix, because then they can't talk to her to fix anything because they can only talk to the daughter because she's head of household. So that had to be fixed first. All right, so we're layering the exchange on top of this, and we're going to have back and forth with Medicaid. Just the degree of problems that we're facing. I just want to put a human face on that.
And I would just say one more thing. The IT system, or the folks that are running out IT system in DC gave us at a public meeting, went through the eligibility steps and the interface, the computer interface, and they made it sound like this is pretty typical in every state. We're talking like half an hour, and I said publicly I couldn't get through this system. You have to have all your paperwork, all your tax returns. You have to have all these questions answered that you were mentioning, and then you have to sit down, and then you have to you have to kind of navigate through this pretty complex series of questions. I don't know if other states or people from other states are concerned about that, but I certainly am.
Rebecca, you had a
Yeah,
question?
I know one of the things on your, Cheryl, on your list was the consumer protection aspect involved in churn between the Medicaid program and the exchange program. And in the best of circumstances, that's a complicated process. But in reality, not every state is going to have an integrated eligibility rules engine, and some of this is going to be dumped into a manual process. We have all sorts of, Patty talked about, we have all sorts of different arrangements in the states. So you have the states that aren't doing anything, or rather it was Sonia, the states aren't doing anything to update their legacy systems in some cases. And then you've got the federally facilitated exchange trying to work with a Medicaid agency to integrate rules with a completely paper-based system. So even if you had this integrated eligibility system, you would have situations in which people are just going to drop out. And if you don't have some sort of safety net there to let them know why they've dropped out and that there's another option, you're going to have a lot of people coming either in one door or the other door, which is supposed to be a single door, that sort of get stopped, and then they disappear because it's not communicated to them where they need to go next. And exchanges, certainly in the further ahead states, are thinking about this and working with existing organizations in the state to sort of do a public education campaign about this. But part of it is technical, and part of it is policy, and a lot of it is about governance. And so I would just sort of echo that from my perspective, in terms of the consumer experience, in terms of retaining people and even getting them to the enrollment stage, that's going to be a huge, huge challenge.
I think that Mary Jo's experience brings up the importance of notices, and our legacy system in Maryland has some of the worst notices.
Oh my God. I had no idea how bad your legacy
as someone who
notices were.
Done a lot of Medicaid eligibility appeal work in fair hearings in Maryland. Some of the worst notices, you can have fun going to administrative hearings on them, but they're there and they're really a big problem, and it's actually one of the things we've focused on in developing the IT system to come, is to try to address that. And I think that that's something that every state is going to have to look at, what these notices are going to look like. And I have to say that these new regulations around what information has to be given in the order and who's going to make a decision first, we really have to think through. We're going to be telling people, almost everyone will get both a you are eligible and you are denied that we're really worried about, right? So there's this group of people, and they're all going to be told, you're eligible for Medicaid, we're denying you subsidies on the exchange. Or you're eligible for subsidies on the exchange, we're denying you Medicaid. All together. And thinking through how to educate people about what that means, and then when it's appropriate to appeal one of those things, and then what appeal to do first.
The notices have to change.
Those notices are changing and will change, but the notices to come have their own set of complexities and problems. I see Judy laughing. It's there.
So I'm going to try to say something positive without sounding Pollyanna-ish, which is that first, I think sometimes we just have to remind ourselves that it's amazing that we're talking about how to implement new affordable coverage options for people. So I just want to remind us, it's so great that we're having this conversation. But I also want to say that there is amazing work going on in states, and Maryland, I think, is a poster child for real integration across exchanges and Medicaid in terms of eligibility determination, really a single door. Even if you're not a sort of MAGI eligible person, you're still going to be able to apply in a streamlined, online or telephonic way. Notices, I completely agree. Not only are we starting from a really horrible place because everybody's looking at the Medicaid notice systems as the starting place, and we do have complicated regs that hopefully we've all commented and said, really, that you're in, but you're out in the same notice, not good. But even in notices, incredible work going on to pay attention to literacy, to pay attention to integration, combine notices for families who are eligible for different things. So I do think that we should be hopeful, because I do think, while it's gonna be aspirational, it's not gonna be perfect in 2014, states are doing amazing work on this stuff. So that's my, hopefully not Pollyannish pitch. Judy?
So, one thing that I've been, many of us have been worried about all of this, and I think the consumer assistance piece is obviously so important, and everybody probably will need some sort of help. And I think what we have to start thinking about, in addition to kind of numbers of people, is how are we going to train them, and having maybe different levels of training, because it seems to me that people, if we sort of think about what we've done over the last decades in getting, kids enrolled in CHIP, it really has been a broad network of helpers throughout kind of communities. But if you think about the complexity that we've been talking about, those helpers are never going to be able to know everything they need to know. When you get, Cheryl sort of alluded to the implications for tax, and how you file your taxes has implications here. If that advice is wrong, you could screw up, your earned income tax credit because you're worried about your health. So nobody's going to know this. So I think, and her point about the law schools, I think, was a really good one, is we need sort of tiers. So we need our sort of community level helpers who can get people in the door, but then we need the, for every 10 of those, we need, 2 experts who can help on some of this other stuff. I've been a little worried about the conversation on consumer assistance, because it really has been more on sort of money and numbers, and not really carefully thinking about knowledge and what they're going to need to know. And maybe that is happening, but it doesn't feel to me that it's good enough in terms of the materials they're going to need, and it feels like we are so behind on that.
There was a question.
I work with, my name's Jackie LeGrand, I work with Sonia at Nashby. I actually was sort of thinking I might be the only person in the room who's actually purchased insurance through an exchange, since I was in Massachusetts and I needed to buy insurance after grad school. And I'm in this room, so I clearly know some health policy, and it was a little daunting, and there's definitely a need, and I didn't, for education, things like having to know what kind of class your drug is, like, is it a antihypertensive, is it they try to break it down, but sometimes you need to figure these things out, because one insurance plan will cover it at 50%, another will cover it at $5. But you also need to have an idea, is that going to save, is that, you have to have an idea of these costs. So there's definitely some, there's an experience, and it was on a scale of 1 to 5 for someone like me, it was maybe a 3, just because I do take some medications. I'm not the healthiest 20-something out there, but so there's definitely some experiences, and I think that, with the right sort of guidance and the right sort of building off experiences of people who have done this, especially in Massachusetts, with different communities, that it's possible that we will get somewhere in the next few years where it will be, easier for people to handle this sort of on their own or with minimal assistance.
Great. On that more positive note, unless there was anyone else who had other questions, inputs, comments, we were going to break for lunch and come back for about at 1:15. We're going to have box lunches. Are going to be brought in
here in the hallway behind us, and you can bring it back in here, or there are, they said, if you go through the atrium and to your left and follow the hallway, there's an area with seating and tables.
The one I was referring to.